afternoon, everyone. Thank you for joining us for the Life, Justice, and Peace webinar series. I'm Jean Welch Hill, Executive Director of the Washington State Catholic Conference. And with me today are my colleagues, Tracy Yackley, Operations Manager for the conference, and David Valmonte, Social Media and Website Specialist for the WSCC. Before we welcome Dr. King, a couple of housekeeping details to mention. We are recording this webinar, and so we do ask that you keep your microphone and videos off so that we have a clean recording. We will send that recording out to everyone who has registered once it's posted to our YouTube channel, which should be early next week. But please feel free to type any questions into the chat at any time, and we will have a Q&A at the end of the presentation. With that, it is my great pleasure to introduce Dr. Natalie King, a palliative medicine physician who specializes in caring for patients with serious illness and nearing the end of life. She attended the University of Notre Dame and medical school at Tulane University, where she founded the Catholic Medical Association student section. She completed internal medicine residency at the University of Utah, my alma mater, and palliative medicine fellowship at the Mayo Clinic in Arizona. After fellowship, she worked for several years as a palliative medicine physician in Colorado, helping lead her hospital's ethics committee and teach trainees. She completed a master's degree in bioethics from the Ohio State University and partnered with the United States Conference of Catholic Bishops to improve education around palliative care for Catholic laity. She's also organized a forum for the Catholic Medical Association on end-of-life issues, and she wrote a book titled Intensive Caring, a Practical Handbook for Catholics about serious illness and end-of-life care, and is now working on a prayer companion. We are so grateful for Dr. King joining us today, and I will turn it over to Dr. King.
Thank you, Jean. It's such a privilege to be here and a joy to speak with you. I love using the image of a sunset as a metaphor for the beauty that I witness in palliative care. For the most beautiful time for a sky is often just before it darkens and the light of the sun fades away. Likewise, there's so much beauty that I see as I care for patients as they're nearing the end of their earthly life. So it's a real joy and privilege to be here today with you and to share this with you. Please join me with an opening prayer. In the name of the Father, and the Son, and the Holy Spirit. Amen. God of compassion, you willingly took on our human condition to experience the same pain, suffering, and death that we do. Through your Son's resurrection, you transformed suffering and death into new life and glory, and you invite us to join our own pain and struggles to those of Jesus. Increase the faith and hope of all who are suffering, especially those living with chronic illness and pain. Strengthen and confirm in them the promise of new life and glory. We pray this through the intercession of Our Lady and in the name of your Son, Jesus, and the Holy Spirit, now and forever. Amen. In the name of the Father, the Son, and the Holy Spirit. Amen. So, as a few background disclosures, I'm Catholic, you probably guessed. I am a palliative medicine physician, so that's my specialty, striving for joy amidst the challenges of our current cultural climate. But I want to also note that this talk really just isn't only for Catholics, and I don't care for just Catholic patients. I really feel that the focus on the sanctity of life and the dignity of life for each person extends to all people and of all faiths and backgrounds. I'm really passionate about this, and I hope you can see that today. And I want to express this passion that you can then share with those around you and your communities. And I want to just note that this is my opinion and not that of my employer. So let's go through the objectives. What I'm hoping to cover today is what is palliative care and how can it be practiced as the Catholic pro-life, pro-dignity antidote to physician-assisted suicide and euthanasia? What does the Catholic Church have to say about the end of life? And what, as informed Catholics, is most practically important that you know for yourself and your loved ones in today's world regarding serious illness and the end of life? All right, so let's get started. Palliative care may be something you're familiar with, it may not be. I remember when I told my parents I was going to specialize in it, they didn't really even know how to pronounce it, so I put the phonetics up. But it comes from the root word pallium, which means to cloak. And when I looked into further what a pallium is, I thought that was pretty cool that it had a Catholic connection. And here's Pope Leo recently stowing the pallium onto archbishops. And so this is something really neat that we think about, and as far as a message or an image of support all around a person who is going through serious illness, cloaking someone with support. And so, a definition I like of palliative medicine is a type of specialized medical care for people with serious illness. And I'm thinking about relief of their suffering from any symptoms related to their illness, pain, or stress, whatever their diagnosis. So, my goal is to improve someone's quality of life for them and for their family, for all the people who love them, working along with their other doctors to help give an extra layer of support. It's appropriate at any age for a person and at any stage in illness, and it can be provided together with curative treatment. So it's important to think about palliative care as something that adds support. It doesn't take anything away. It's something that can be there for children, it's something for the elderly, it's something that can be helpful at a time of diagnosis or maybe a relapse of disease. The goal really here is to help you live as well as possible for as long as possible. We say, yeah, we know you have this serious illness, but that doesn't mean that life stops. How can we help you keep going and have the best meaningful life you can, even though you may have something that may not be curable? Palliative care is something that can happen in the hospital. It can happen in the community setting, like a clinic. It can be part of a cancer center or a heart failure clinic or other specialties, and it can be a home-based service. And palliative care really came on the map when they studied patients with end-stage lung cancer. And they saw that patients who had a palliative care team versus those who didn't lived longer and spent more time out of the hospital, which generally equates to better quality of life. An image that I love to think about with palliative care, and one that the church has really supported, is that of the Good Samaritan. Palliative care is accompaniment. It's walking with someone. It's not abandoning them. And when I see a patient who has a serious illness, I walk with them and their family through the course of their illness, respectfully accompanying the dignity of their life, working to live it to the full, to the time of their natural death. You can imagine how misunderstood I felt the time a colleague came up to me in the hospital and said, they just assumed that I was supportive of assisted suicide. If all my patients chose to prematurely end their life by assisted suicide, I would literally have no job. I would have no patients. Assisted suicide is the antithesis of good palliative care, not to mention in direct opposition to everything that my faith teaches. So the Catholic Church uses the image of the Good Samaritan as the model for the dignified care that we're meant to give others, which I'll expound on a bit in a moment. So you may be familiar with these practices living in Washington. I know that many of us have heard these terms on the news, or may know, you may even know someone who has thought about assisted suicide. But I'm going to just take a moment and work through the definitions of what they are and how they're different, and kind of the state of things right now in our country and the world. So, physician-assisted suicide and euthanasia, they are similar practices. So, in both, a patient's death is hastened, but they're different. And I'm going to talk about that because these terms should not be used interchangeably. So in physician-assisted suicide, or PAS, some people may call it physician-assisted death. Some may call it physician-assisted killing. A lot of people are calling it medical aid in dying. So they're taking out physician, they're taking out suicide. But it's the same thing, okay? They're all the same thing. A physician writes for a lethal dose of a medication, which the patient takes with the goal of prematurely ending their life. Okay, so now we're going to focus on euthanasia. Euthanasia is slightly different. It notably is different from a physician-assisted suicide in that in this, a physician will actively administer a lethal medication or lethal drug, essentially, to a patient with the intent of ending their life. So euthanasia comes from the Greek eu and thanatos, which means good death. And so it's more of an active process, whereas physician-assisted suicide is like a little more passive because they're just getting prescribed something that then the patient consumes themselves. So physician-assisted suicide is legal in some states in the United States, including Washington. Euthanasia is not legal anywhere in the United States, but both are passing in more places around the world. Eligibility varies by state. But typically, for physician-assisted suicide, a patient must be 18 years old, must have an advanced illness that is considered terminal or with an expected life expectancy that's pretty short. And often that's 6 months or less is kind of the framework people use. And in some states, a mandatory psychological screening is required, but in other places, not. So this is just a chart of Colorado. So Colorado passed assisted suicide in 2016. And then in 2017, they started being able to prescribe the drug cocktail. And so you might say, is this really, changing over time or more people choosing it? And the answer is yes. So, and we see this in other states as well. But in 2024, 510 patients received the prescriptions for the aid in dying drugs under the provision of the Colorado End of Life Options Act. And this is a 28% increase compared to the year before. And from that year to the year before that, it was a 23% increase. So it's changing a lot each year. And so here's a map of the United States, and you'll see the states in red where physician-assisted suicide is legal, and you can see in purple where it's likely to be starting this coming year. So a lot more people are going to have access to this practice. And this is a map of the world. The light blue would be where assisted suicide is legal. The dark blue is where euthanasia is legal. And so the dark blue, that's currently legal in the Netherlands, in many places. You can see the map. The Netherlands, I'm just going to talk about briefly because they were the first country to legalize it in 2002. And as many places have legalized these things, they try to work the law so that over time, it's kind of like they call in ethics a slippery slope, but like one thing leads to a kind of a more worse thing, and they will expand the law and make it more accessible and easier to get. And so this is an example of the Netherlands because it first was for someone with unbearable suffering related to a terminal illness. But now euthanasia is including children, neonates, and those who have diseases like depression or dementia. So it's really changed. Okay, so I'm going to do a quick spotlight on Canada because I think this is very telling as well. And so euthanasia, so again, the lethal injection, that was legalized in 2016. They also have physician-assisted suicide, but when both practices are options, this is what people often choose. So this is what happened in 2016. And then in 2021, it was advanced, the slippery slope. 2021, euthanasia was legalized for people with disabilities and for people with chronic diseases. So that would be things like heart failure, chronic kidney disease, COPD, you name it, a lot of these things that don't have cures. So in 2025, more than 16,000 people died by physician-assisted suicide or euthanasia in Canada, and this is over 5% of all deaths. So since 2016, over 76,000 people have died from prematurely hastening death. And so this is what's happening. And even next year in 2027, this may expand to people who have mental illness as their sole underlying condition. So it's also very alarming to hear the number of stories about patients who feel this is an option that's pushed on them by their hospital, by their physician, the very people that they're looking for help in living, not in dying. So I'm going to now pivot a little bit to talk about what the Catholic Church has to say about the end of life and what it has to say about palliative care. So, the Catholic Church condemns both suicide and murder. These violate the fifth commandment, thou shalt not kill. The Catechism of the Catholic Church specifically states that suicide is an act gravely contrary to the just love of self, and that voluntarily assisting another in their suicide is contrary to the moral law. In 2020, the Dicastery for the Doctrine of the Faith wrote a letter called Samaritanis Bonus, which means the Good Samaritan. And the subtitle is On the Care of Persons in the Critical and Terminal Phases of Human Life. And it says, whatever their physical or psychological condition, human persons always retain their original dignity as created in the image of God. Someone's life is for them to give, not for them to take. Euthanasia is a crime against life and an intrinsically evil act in every situation and every circumstance. And this document, Samaritanus Bonus, I really recommend looking into. It's not just for doctors or ethicists or priests, even. It's for anyone who comes into contact with someone who is sick, someone who is dying, healthcare workers, family members, pastoral workers of any type. It really hits the advancing anti-life culture, the culture we're in of assisted suicide and euthanasia, it hits it head on. Because why is assisted suicide and euthanasia attractive to the anti-life culture? Because of a desire for control and autonomy. Because deeply inscribed into our culture today is a sense that to have a life worth living is to live on one's own terms and to make one's own choices. That's not bad in and of itself. But the reality is that aging and getting sick can start to hinder one's ability to live life on one's own terms and reduce the range of one's possible choices. Aging and getting sick remind us that in reality, we're not in control, that our control's always partial, that we're always dependent. So, how do we respond in the face of this reality? The pro-life stance, the one that I believe, the one that I'll share more soon. But the anti-life culture, the one I don't believe in, but the one we all live in, is the one that prioritizes calling one shots. The anti-life culture responds to this reality in a different way, seeing life without complete personal control as unacceptable, leading some to seek only more control over their life, even to the point of derailing and detailing exactly when and exactly how they will die, even if it means taking their own life. So, what does Samaritanus Bonus say? It says, to end the life of a sick person who requests euthanasia is by no means to acknowledge and respect their autonomy, but on the contrary, to disavow the value of both their freedom, now under the sway of suffering and illness, and of their life, by excluding any further possibility of human relationship, of sensing the meaning of their existence, or of growth in the theological life. Because as Catholics, we don't believe that your life stops with a diagnosis or that you have less value now that you have limitations. We believe that in the value of your life as so much more than that. We're meant to accompany people on the journey that God directs. It's not ours to direct. Willfully ending one's life takes away their autonomy and their freedom rather than imparting it. So my personal experience with physician-assisted suicide and euthanasia, they're real things. I mean, you know this, living in Washington also. I think before I just thought they were ideas far out there that someone else, theoretically dealt with. But no, these are real. These are happening. The culture is on a slippery slope of desensitization, and these laws people are working to get them expanded. More legislation is coming. And as Catholics, it's not enough to say that we're just opposed. We need to be proactive. We need to be on the offense, and we need to be empowered ourselves about these things and to educate others to share the truth about what's going on. And so there's different ways to fight this battle. Some of the ways that have been successful has been those advocating for disability rights. I mean, these groups are really getting targeted, and they've made good advancement sometimes in the legislative arena, but also just lobbying in general and educating and bringing awareness. Advocacy and education efforts are so important, and not just you have to scream it from a mountaintop, but no, just talking to the people in your neighborhood, talking to people in the workplace. So many times I hear things that people, misunderstand what's going on and what's happening. And there's actual, good work being done too in the pro-life arena and in medicine around these. But it's true, there's so many misperceptions out there. And even if you're the kind of person that it's a bit nerve-wracking or, you don't feel comfortable going out there and doing some of this, one thing you can do is just promote and share the truth about the antidote, which is pro-life, pro-dignity, palliative care. And I'm going to talk more about that. So what I'm talking about here is really true accompaniment. Palliative care, this medical specialty that's going to really work on optimizing human flourishing. The Catechism of the Catholic Church says palliative care is a special form of disinterested charity. As such, it should be encouraged. Physician-assisted suicide and euthanasia, they destroy the therapeutic alliance that is meant to be inherent to medicine. Palliative medicine is looking at elevating the humanity of the person, looking at the person beyond their disease, supporting them, supporting their family, helping to understand their goals and values. It emphasizes their intrinsic dignity and works to optimize their flourishing. Palliative medicine is not a euphemism for euthanasia, but I believe the antidote to the assisted suicide and euthanasia movement. It really needs to be the Catholic response, and it has been, which I'm so grateful for. Because this integrates medicine, it integrates modern technology, it looks at the vulnerable and infirmed patient, and it says, you matter. It radically loves the people that the utilitarian, function focused culture that we live in says that they have no value. We need to champion palliative care and advocate for it. Practice this way, not another concept usurped by the culture. To be clear, rather than turning away from our current healthcare system or falling into cynicism about it, I think this means our involvement in healthcare as Catholics is so vital, whether it's in professional roles like physicians or nurses or social workers, or volunteer roles, or just caregivers as to our family members or friends or neighbors. We need to restore and reaffirm the dignity of the person in healthcare. I often hear or read about supporters of assisted suicide who argue that the Catholic Church, their view of assisted suicide and euthanasia means that it just wants people to suffer. That is not what the Catholic Church says. Just because the Catholic Church is opposed to physician assisted suicide and euthanasia does not mean that we are meant to needlessly suffer. Not at all. The root of what the church believes in is not in suffering, but in dignity. And I think to help clarify this, we need to talk a little bit about the word dignity. This word gets invoked a lot in arguments around the end of life, and it's used in different ways by both sides of the argument. So when people get old and may be debilitated or dependent upon others, this can be seen by some in our culture today as a life of diminishment, or it can feel like an assault on someone's dignity. This is attributed dignity, the value that we confer upon another person, like someone saying, this is below my dignity. However, the sense of dignity that the Catholic Church uses is different. The Catholic Church, when they're thinking about dignity, is using intrinsic dignity, the quality that a person has only by nature of being a human, the sense that everyone has no matter what, just by virtue of being a human person. They have this dignity. It is clear that someone's attributed dignity can be assaulted by illness or by debility. But the central question is that all there is? Palliative care works to relieve attributed dignity by helping to give good relief of suffering by improving all this different suffering that they may be experiencing. And the Catholic Church supports this. The Church supports good treatment, meticulous attention to managing concerning symptoms and pain. And I, like other palliative care doctors, did extra training focused specifically on this. But the Church and myself as a Catholic draw a line and say that the reason we're doing all this attentive care and the reason that I'm in this field is that I value you as a human being, your intrinsic dignity. And it's never okay to end the life of another human being or to say that the life is not worthy of being lived, that it has lost all value. That thinking goes against one's intrinsic dignity. So Pope Francis did a lot of speaking and study about this throwaway culture that we live in. And he's criticized this, where this throwaway culture where the victims are the weakest human beings who are likely to be discarded when the system aims for efficiency at all costs. This utilitarian view of quality of life holds that only lives that have certain functional abilities or lack discomfort deserve to continue. So this throwaway culture we live in it doesn't believe life has a value in and of itself. And so there's this sense of radical individualism that comes up. The other is viewed as a limitation or a threat to one's freedom, a burden. There's isolation and less dependence on others, which is inherently false because at our deepest level, we depend on God and on others. This throwaway culture says that autonomy is the highest good, that one has rights to do whatever they choose, and that extends to how long I live my life, where assisted suicide or euthanasia may come in. And then there pervades a sense of misguided compassion, because in situations where one is seemingly suffering, some might view that ending their life is being justified in the name of compassion, holding it's better to die than to suffer, and that it would be compassionate to help a patient die by means of euthanasia or assisted suicide. So this cultural phenomenon, it's deeply contrary to solidarity, which John Paul II has really strived for. And This this cultural phenomenon is something that some have termed the culture of death because it gives rise to real structures of sin. Assisted suicide and euthanasia arise as erroneous solutions to the challenges of caring for terminal patients. And so I want to just contrast this culture of death, this throwaway culture, versus what the Catholic Church is teaching, a culture of life, teachings emphasizing love and life. So, as we mentioned earlier in Samaritana's bonus, whatever their physical or psychological condition, human persons always retain their original dignity as created in the image of God. God's call is to appreciate that human life is the primary good of society. Human life is the highest good, and society is called to acknowledge this. Life is a sacred and inviolable gift, and every human person created by God has a transcendent vocation to a unique relationship with the one who gives life. As opposed to radical individualism, the Catholic Church teaches accompaniment. We've talked about that. And as opposed to misguided compassion, the Catholic Church teaches and this beautifully described contemplative gaze. And it says, we are meant to behold in one's own existence and that of others a unique and unrepeatable wonder, received and welcomed as a gift. This is the gaze of the one who does not pretend to take possession of this reality of life, but welcomes it as it is, with its difficulties and sufferings, and guided by faith, finds in illness the readiness to abandon oneself to the Lord of life, who is manifest therein. And so when I think about my role and I think about for you to learn about what is, you might be thinking, what does a Catholic palliative care physician look like? And when I think about this, several descriptors come to mind. I describe myself as an advocate, speaking up for patients because of their health situation, and they might be quite vulnerable. I describe myself as a guide, helping others navigate the sometimes overwhelming healthcare system. I describe myself as a counselor, helping people make healthcare decisions that they can feel peaceful about and inconsistent with their values. And my favorite, I describe myself as a cheerleader, helping patients see that not all is lost because of their health situation and working to help reinstate their hope and their joy despite their struggles. So now I'm going to bridge into my third objective. So, how, as informed Catholics, like what is important practically that you and your loved ones know? And I think I'd like to bring this scale image up because I think that it's very tricky and it's hard with the variety of healthcare situations that we or our loved ones might be put in. And thinking through the balance of how can we live well, but not cling to life unrealistically? And how can we die well and not ignore the dignity of life, especially when we cannot cure? Because as Catholics, we're not meant to be vitalists or saying life at all costs. We understand we're mortal. And as we weigh these things, but I mean, we're mortal, but we also really value the sanctity of life, so it's like, how can we live in that balance and that tension? And so the way that the church has kind of taught about this is it looked at things kind of as something extraordinary or ordinary. You might have heard of extraordinary or ordinary care. Something ordinary meaning basic, necessary, extraordinary, maybe more extra or optional. But in recent years, they've switched kind of to a different framework that has been helpful, and that's using the terms proportionate or disproportionate, and that's thinking through healthcare options. And the proportionate is really meaning something is more beneficial than burdensome, whereas something disproportionate would be more burdensome than beneficial. So the key here is that something proportionate would offer reasonable hope of benefit without imposing disproportionate burdens. And so the key is in the eyes of the patient, is this healthcare choice, whether it's dialysis, whether it's chemotherapy, whether it's and going on the ventilator machine, whatever it is this in the eyes of that patient more beneficial than burdensome? If so, we should do it. If it's truly more burdensome than beneficial, then that might be something that we say, you know what, this is disproportionate. I'm not going to choose it. And doing something like that does not mean that this person is suicidal or they don't have respect for life. So the key is is thinking about, is this something, this treatment, this intervention, this surgery, whatever, and fill in the blank. What can this do for me? What can this do for the person I love? What harm can this do for me, for the person I love? And kind of using that as your gauge. So I'm going to give a couple examples because I think it'll help to frame it. So we have two patients. So let's look at our first one. She's 40 years old. She's otherwise healthy. She has a genetic kidney condition called polycystic kidney disease. And so she's been following with a kidney doctor for years. And unfortunately, her kidney failure has progressed to the point where the doctor says, your kidney's not working. You need to go on dialysis, which is basically like life support machine for the kidneys. So if you contrast this with an 80-year-old man, he has advanced dementia, hearing and vision loss. He lives at a nursing facility. He has advanced heart disease that has in turn impacted his kidneys, and he's now developed kidney failure to the point of needing dialysis. So as you think through these two patients, does one of them seem more proportionate or the burden is outweighed by the benefit? What good or harm could dialysis do to each patient? I'm not going to give you a right or wrong answer here because I've seen patients in both scenarios who choose both options because that's the key. It kind of in the individual's view, but you can see how in some places it seems more clear that something is more beneficial than burdensome or the other way around. But many patients find themselves in quandaries like these, and that's where my specialty, palliative care, can really come in. And so I put this graph up to kind of talk about the difference between palliative care and hospice. I often find people use these terms interchangeably, and they're not the same thing. So it's important that you know the difference and that you can help your loved ones or friends kind of know how they're different. So palliative care is this big medical subspecialty focused on helping people with serious illness live the best life possible. There's a subtype of palliative care that's called hospice. So hospice is its own little thing within palliative care, but not all palliative care is hospice. So if you think about I have this top bar graph that talks about the traditional approach. So that's like a patient gets diagnosed with advanced cancer and they hit the ground running with their oncologist. They're taking chemotherapy, or getting radiation. They're just doing everything they can to kill that cancer. They might have a relapse. They might need another line of chemotherapy because the first one didn't work. They have progression of disease on the scans. They're just in and out of the hospital all the time. The doctor finally comes to them and says, there's nothing more I can offer you. I'm going to focus your care now to be comfortable. That can be a very sort of grief-stricken and traumatic transition point because you weren't really feeling prepared for it. You had your foot on the gas, and then the doctor just comes and slams on the brake because there's really nothing more we can do. So palliative care came in here to say, right from that time of diagnosis, so the second bar graph, you're going to be hitting the ground running with your oncologist. You're going to be doing everything you can to fight off this cancer. But at the same time, you're going to be introduced to palliative care. This is a support team that's going to be able to walk with you. You may not need them that much in the beginning, but over time, you might be like, well, I'm getting some shortness of breath from my tumor, or I'm finding that I don't have the energy I used to, or I'm finding that I'm having some pain in my feet. And maybe palliative care can kind of work with your cancer team. Or you want to say, how do I tell my kids about this? And the social worker on the palliative care team can kind of help. And you find that over time, you might be getting more support and more meaningful help from this palliative care team on the personal, like whole person side of who you are, in addition to getting your chemotherapy. At some point after working through all this and working with your team and kind of talking through it, you might say, you know what, I'm ready to transition to like not going back to the hospital all the time. I kind of don't think chemo is helping me anymore. It's becoming disproportionate. The burdens, all the side effects, keeps putting me in the hospital. That outweighs the benefit. I don't feel it's actually helping my cancer shrink anymore. And I'm feeling so tired and I'm ready to just be with my family and be comfortable and live my life at peace with, at home. That's when the transition to hospice makes sense. So all along you have this palliative care, and then at that point you transition to hospice. And that's meant to be very smooth and very peaceful for you and for your family. And so I like this quote, and I like thinking about this sort of suffering that we look at in palliative care as total pain. Cicely Saunders helped found the hospice movement, and really it's all the encompassing physical, emotional, spiritual, and social suffering that patients may experience near the end of their life. And she said, you matter because you are, and you matter to the last moment of your life. We will do all we can not only to help you die peacefully, but also to live until you die. So it's a really beautiful way kind of to think about the work we do in palliative care. And I put this slide on because it gives a sense that none of the work that I do is linear. Every patient is different. Every patient is unique. I sometimes laugh with my team that when we enter a patient's room, I work primarily in the hospital. And so often I'm greeting patients and families in a moment of crisis or serious illness, that's really come to a head. And you never really know when you enter into that room what's going to be at the forefront of the patient's mind. It may not be relief of physical symptoms and pain. It might be spiritual distress of why this is happening. It might be anxiety. It might be their financial situation. And my team, I work with nurses and social workers and chaplains, and really working at address that total pain, working at addressing what's going on. And sometimes when I meet patients and there is a lot going on, I ask them to kind of rank your quality of life to me on a scale, 10 being the best life ever, and 1 or 0 being life in the pits. And where would you put yourself? And if they say, well, I'm a 3, I'm like, oh, well, how do I get you to a 4? What would that look like? What would have to happen to get you to be a 4 or even a 5? I mean, that's kind of how I work to kind of get that scale, that number up, working to make that patient have a better life. And so when we think about the kind of suffering people might have, a lot of people ask me or they have concerns about pain. And I think that's a fear a lot of people have is pain and treating pain. And so as Catholics, how do we address this? And I want to let you know that there is actual documentation from the church guidance on this. And the Ethical and Religious Directives is a beautiful document that helps guide Catholic healthcare services and Catholic hospitals. And it specifically addresses pain. And as Catholics, it's okay to treat pain. People should be kept as free of pain as possible, while at the same time really working to keep them as fully conscious. Pain's medication intent is not to hasten their death. It's really about the intent of relieving that pain. So, what's the lowest dose I need to help take the edge off to where you can sleep through the night and have a conversation with your family and relieve that pain so that you're not dealing with it all the time? And it's kind of going back to this ethical principle called the principle of double effect. So, when I'm treating someone's pain, it's about the intention. My intent can't be to just sedate someone or hasten their death or do whatever. I'm here to just help make them feel better so that they can keep living their best life. And sometimes, this is their end of their life and I'm helping relieve that journey and I'm with them on it. But my pain medication relief is for the pain itself. It's not for anything else. So I also am working at looking at emotional pain, spiritual pain. All these areas need to be addressed in someone's life or else the physical pain is not going to be adequately managed. And so here's just an example, a 72-year-old gentleman with stage 4 colon cancer. He's developed significant pain in his abdomen. He can't sleep through the night. He can't really rest during the day. He's tried over-the-counter pain relievers with no success. And for this patient, what should be tried next? It should be attempting an opioid. And really, an opioid for a patient with significant cancer pain is the standard of care. And an opioid is a medication like morphine or oxycodone. And these medications in palliative care, we are trained to view them, in a different light. And we are really working to manage them safely and, securely in a way that is looking at helping relieve that symptom. And we do risk assessments. We look at, does this patient have a family history of substance use disorder? Are there other high-risk behaviors or safety concerns in the home? We talk to the patient about side effects. We talk about how they may develop tolerance to a medication, but that they're not just going to get addicted and then get all this, go rob a bank to get more medication to, do something. It's funny how people think they get really scared. And I want to reassure them that just like for diabetes, you need insulin. For severe cancer pain, you need opioid medication. And so my goal is to keep you as active and functional as possible, not sedated. And that I talk through the side effects of these and we figure out a safe plan to treat them. And if a patient's pain goes down, maybe their cancer is shrinking or getting treated in other ways and they're doing better, then we work to wean it down. So it's really a safe way that we can help people feel significant comfort. A lot of people also ask about artificial nutrition and hydration. So traditionally, Catholic teaching describes this as an ordinary basic care. Everyone should get food and water. However, it is important to know that there are instances where artificial nutrition and hydration can be considered disproportionate, or the burdens of it can outweigh the benefit. And so, for an example, when death is imminent, the body is unable often to assimilate successfully food and fluids. So if you're just pounding someone with nutrition and hydration through a feeding tube, you actually might be contributing to swelling, to shortness of breath, to making them more uncomfortable. And so it's a very important conversation that you would have with your medical team or your hospice team. And it's a very individualized discussion, but it's important to note that this can also be considered disproportionate in certain circumstances. So, briefly, just to mention a few case examples again, we have a patient who's 48 years old with esophageal cancer. He's planning on chemotherapy, radiation, and surgery. He has very significant cancer burden in his esophagus, so he can't really swallow. He's lost a lot of weight. So, would a feeding tube likely be proportionate? Contrast that with an 84-year-old lady with permanent debility from a stroke. She lives in a nursing home. She's dependent on cares. She's incontinent, like she can't toilet herself. She needs to be bathed and fed. Her favorite things are eating ice cream and watching movies. She's had 6 hospitalizations in the past year for pneumonias due to aspirating, food going down the wrong pipe, her ice cream or whatever. We've tried to work with her in the hospital. The speech therapist has tried to help her with swallowing more safely. The dietitian has tried to modify the thickness of her foods so that she won't aspirate as much. In the hospital, care has been really challenging because of her debility, and she gets easily confused. She can't really tolerate having IVs. She's always pulling them out. She's getting agitated in the hospital. So for her, would a feeding tube likely be proportionate? So again, I'm not going to tell you a right or wrong answer, but you can think through how different scenarios, it makes the same thing quite look different. So in my years of practicing palliative medicine, I've met many people and many Catholics who have felt quite frightened, to be honest, of palliative care. And it's not just because they're frightened or avoidant of death and dying, but it's because they fear that their palliative care team is going to hasten their death or, promote the end of their life sooner than necessary. And that makes me very sad because, yes, I acknowledge that there are people in palliative care, just like in every other medical specialty, who are practicing in immoral ways, just like there are obstetricians and gynecologists who celebrate abortion. There are palliativists who embrace and celebrate physician-assisted suicide and euthanasia. But definitely not all of us. There are those of us who are fighting for life in this area. And I think we all must advocate and educate about the good, true, and beautiful of palliative care. And if those on this webinar today if there's those that are considering a career in healthcare, I invite you to consider palliative care as a way you really can meaningfully live your faith. Palliative care can really be the antidote to so much of the suffering near the end of life. It's aiming to give value to the person and help give meaning to their experience of death and suffering. And like I've mentioned, assisted suicide directly undermines our goals. So we're here to treat the suffering, not eliminate the sufferer. Briefly, we don't have too much time, but as a Catholic, I think it's really important that you have good advanced care planning. And these are things like a living will, a power of attorney for healthcare decisions, or maybe a DNR form. These are all things that are considered advanced care planning. But when you're thinking about doing these forms and if it's right for you, I think it's just important to realize like these forms, their purpose is to communicate your values to those who could be making decisions for you if you couldn't speak for yourself, or to help guide your medical team. And so as Catholics, it's important that we convey how we feel according to our beliefs to help ensure that our religious and ethical beliefs are respected. And so 3 things that I just think are important for Catholics to keep in mind when completing advance directives are: 1, to be particular about choosing your medical surrogate decision maker or your medical durable power of attorney. So typically by law, it defaults to like your spouse, your adult children, things like that. But what I always tell people is that it's very important to find someone who knows your values and someone who can follow your values and your wishes. Because if you have a medical power of attorney, they're going to be called on in a moment that you couldn't speak for yourself. You are on a life support machine, or you are so sick, you are confused or sleepy. And so you want them to follow your directions. You want them to know what you would want and then to be able to emotionally be able to handle this difficult time. And you want them to be able to be accessible. So practically, can the doctor reach them at 2 in the morning if you are on a ventilator and you can't speak for yourself and they need to know whether to give you a certain treatment? So it's all like very important. And so the second point, I would limit yourself to the extremes on forms. Some of these forms have checkboxes. Some of these advanced directive forms are like all or nothing language. And I would really restrain from saying, like, I would never want any tubes or life support machines, or I want everything possible to live as long as possible. Because both of these scenarios aren't that realistic when it comes down to time to things. And in a context of your healthcare, it might be very prudent actually to like go on a ventilator to fight your pneumonia and then you get off of it and you have 10 more years of good life. So it's important to kind of think through this very thoughtfully. And often I think the best thing is just having a medical durable power of attorney that you really trust and you know that they would be able to advocate for the sanctity of your life and your wishes. And then the third thing is these forms are only as helpful as the people that have them. So get them to your doctors, put a copy in the glove box of for your spouse in their car or whoever is your power of attorney, take a picture, have it on your phone. We want these to really be helpful. Okay, so there's a document out there that's a great article about what Catholic advanced directives should include. These are just quickly like saying pain management's important to me, looking at things as proportionate or disproportionate. In general, we would favor nutrition and hydration if it's going to be proportionate. We are against assisted suicide. Getting a priest is important. You're mentioning like getting viaticum and sacrament of the sick. Those are all really great things that you can include as a Catholic in your advanced directives that would be really helpful for your healthcare team to know. So if you're thinking about how would I get palliative care, you can get a referral like you would for a cardiologist or a kidney doctor or anything. You can also ask for it. You also can think about it's covered by insurance also, just to know. People ask me that. And when is it appropriate to have palliative care? I think anytime there's stress in the setting of serious illness. So if you're considering it, I would just say yes. It probably would be helpful and it wouldn't hurt to have a consultation. So I'm going to keep going because of the interest of time. But I just want to close by saying one of my responsibilities, I think, as a palliative care doctor, is to reinstate meaning into the patient's life when they observe it to be absent. I don't have an agenda. I work to understand the patient's agenda. I want to help restore dignity. And despite whatever significant ability they have, I want to generate positive activity in their life and in those of others. I hope this talk today has helped to impart the gravity of the issues facing the end of life. Respect and reverence for the lives of people seriously ill, it really spans the spectrum. It's a pro-life issue for sure. It's a social justice issue for sure. It's truly a human rights issue. It's important that we know about. And we're all going to have the opportunity to fight for the dignity at the end of life in your workplaces, your neighborhoods, and in your families. It's about seeing people as the gifts they are, not burdens. And it's about having special reverence for the handicapped and the elderly and sick, anyone who's vulnerable. It's about not fearing suffering and about letting others you know who are suffering know that they matter and that you are with them and you will not abandon them, what they're going through. And as we continue on this journey on this mortal life, and as we accompany others, may we always remember our Christian hope, which gives us true courage. We cannot be afraid of our future, of suffering, or of death, for we live in the redeeming love of Christ. Thank you so much.
Natalie, thank you so much for this very comprehensive presentation. All of the questions that came up from you answered as you went. So, but we do have a couple of questions, so let me get to those. Amy asks, she agrees with the observation about the primary motivator being loss of control, and we hear that a lot in folks talking about assisted suicide. But there's also very real issues of not being an economic burden, especially with the rising costs of healthcare. And I'm paraphrasing her, so I apologize, Amy. This is not exactly what you said. But I can see some considering these options due to practical realities, such as inability to access needed caregiving or trying to save money needed for one's own caregiving in order to keep those financial resources available for an elderly spouse or one's children. So this is partially an issue related to the control, but it's also a reflection of economic issues and significant barriers in access to caregiving. What advocacy strategies can you recommend around the gap in affordable, safe caregiving in our communities?
And Jean, you feel free to weigh on this too, because I think you've done a lot with, advocacy work. But
Yeah.
I mean, I think for one is helping our loved ones know that they're not a burden. I mean, I'm not an economist or, I wish I had more financial support. I mean, I want you to know that palliative care has embedded social workers. So we're always looking at the big picture and the financial and the worries that patients have. That's usually like so forefront of their mind. So that's something we really take into consideration when we're walking with them. But I also just want to be um, it's so important that I mean, I've had patients who just think they have to do something because their loved ones would not want to care for them or that, and I think letting people just truly have honest conversations and show your love in those moments.
And we will, please join the Washington State Catholic Conference Advocacy Network because we will see some assisted suicide legislation this coming session, but we'll also see a lot of budget cuts that will make that access more of a critical issue. And so that's part of the advocacy we do is constantly advocating with our legislators to make healthcare more accessible and affordable for folks. And we will be doing that in the 2027 session. Another important question from Amy, can you speak to the rise in voluntary stopping of eating and drinking?
Yeah, I think that's part of this, the whole spectrum of assisted suicide. For example, some patients will not meet the criteria for the aid and dying cocktail. So they will want to take things into their own hands at their own time when they're ready or whatever. And so they will work through stopping eating and drinking on their own, like starving themselves. And sometimes their physician, I've known in some places, will kind of make a plan and help guide them. And so if people haven't heard of that, that's kind of what she's referring to. And it's the same thing. I mean, helping to let them know that before they get to that point, that point of despair and to know that their life is a gift and that we want to help them keep living and in a way that is meaningful and to know that they have value because so much of these desires are rooted in a sense of feeling of loss of identity, loss of worth, loss of value, and to reinstate that for that person.
That's great. Thank you. Culturally, are we on the precipice of these options being seen as more socially responsible than natural death?
I worry about that. I mean, I think people are feeling pressures, and if they're not well informed or they don't have this sort of background about the dignity of the person that I think sometimes gets lost in our culture, like I spoke about, then they so easily may fall into that. And so it's just again important to fight this pervading cultural attitude.
Agreed. And I will say on that particular question, I mean, that is part of why, we do need to be that Catholic voice in the public square because there is, and it's why the disability community has actually been very effective advocating against assisted suicide laws because that idea that somehow if you have a disability, you don't have worth is really quite, I mean, insulting is a mild word for what that says to folks who live with disabilities. And that is a culture that we do have to constantly fight against. Let's see. An explosion of euthanasia is looming as a whole generation chooses not to have children. Why continue? Who will take care of me? How do we address that lack of caregivers, family caregivers for folks?
Yeah, these are wonderful questions, and I wish I had some of these answers. And I think we have to just um, think about, sometimes our family is not going to just extend to our biological family. I mean, we might have a friend who's like a family, and that's who we're going to be caring for. And it's not that this person doesn't have, because they might not have children, like the traditional people that are caring for them, that doesn't mean they don't deserve meaningful care. And yeah, I agree. We have to be thinking down the line about systems in place to help support these people so that they know that they're going to be supported.
And agree. And somebody asked how you join the network. So I have put in our link to join our network because that's another piece that, we need to advocate on because this view that we hear that, people choose assisted suicide for pain or lack of control. But honestly, there's a lot of concern about people aren't really choosing it. They're feeling forced into it. And that's something that, we have to keep bringing these kinds of arguments to our legislators so they hear that. And here's another great question for you. When so much of modern society subscribes to a utilitarian view, How do we engage them regarding the importance of human dignity? Approaching them with religiously founded arguments would likely be counterproductive, especially in Washington where religion is not very respected. Is there a strong secular argument, thinking of biological, embryological arguments against abortion?
I mean, I think a lot of what I do is like I'm here to help. I'm a physician to help restore health. I didn't go to medical school to kill people. I'm here to help take care of you. It's an antithesis of my um, sacred oath of supporting you, and it's what medicine is meant to do. And I'm just because like I'm not going to stop. I don't know. Giving you something to kill you is the opposite of what I'm doing. I'm not going into this field to kill people. So I think sometimes it's caring for it's that dignity. I think the intrinsic dignity argument also is not just a Catholic piece. I think that can be extended to all people. A person is worth more than their functionality and their disability. That doesn't like define them. And so I think you can totally use that as well. And I just ask people if people talk to me like they think palliative care and they think I'm here to hasten their end of life, or at the bedside they just say I'm ready to go bye-bye or give me the pills, or they tell me whatever. And I say, well, wait a minute. Like I really think that there's a lot of people that love you. I think I'd love to get to know you more and care for you. And can we walk together a little bit? Would you let me kind of make life a little better? Would you let me talk to you and kind of work through this and just give me a chance to be a doctor to care for you? Then often I think the door can be opened because it's often there's such a place of despair and fear where they're coming from, and that just breaks my heart.
And I just thank you so much for that because I know having, been with a loved one who got a terminal diagnosis and just it was very professional, but no real connection to the emotional and spiritual devastation in that very moment. And so what you do is so incredibly important. So thank you for all that you do. I got one last question for you. When assisted suicide is presented as an issue of compassion or personal choice, how can Catholics explain clearly and pastorally that true compassion protects human dignity and the common good? What role can ordinary Catholics play in that public conversation? Much of it you've talked about, but one last opportunity.
I think just saying like again that whole intrinsic dignity. Like we can say, yeah, this is below your dignity. You shouldn't have no one should have to have that pain. No one should have to be bedbound. No one should have to be dealing with what you're dealing with. But you are so like loved and awesome, and God created you. And I mean, you don't have to again if you're trying to do secular arguments to take out there, but you are like an awesome person that I care about and I want to see around. And I don't want, let's figure out how to make life a little better for you. And sometimes it's being really creative. Like their lives, they can't get the food that they used to love, or they can't get out and be with people, or they've lost their sense of they can't care for their grandkids anymore. We have to be creative and we have to be kind of proactive to think about these losses that are then demoralizing people to feeling like life's not worth living. So how do we get that back? So, I mean, you may have seen the movie Patch Adams, and they like a patient like doesn't want to get care, and they're trying to figure it out, and she wants to swim in a swimming pool full of noodles, and it's ridiculous and crazy. But then she's like doing better, and so I think about sometimes with patients like, what's your swimming pool full of noodles? What is it that could get you over the hump here to realize that, yeah, you may not be traveling to Egypt again, which is your favorite place on earth, but we're going to bring Egypt to you and in a creative way. And we're going to, life is still okay, but let us help you. It's going to be different. We have to reframe it, but it's still worth living, and you are worth it. So maybe that.
I'm going to use that phrase. What's your pool of noodles? Thank you again, Dr. King, for this very, very comprehensive, very practical look at the end of life. It's an issue that touches all of us at some point. Your expertise is very clear. We're very blessed to have you sharing your experience with us and how we can help promote that culture of life. Many thanks to everybody who attended today. We hope that you will subscribe to our Catholic Advocacy Network as we take these issues to the Washington State Legislature. And we will have a variety of bills we know that will impact life and justice in our state in 2027. So please join us, and please join us for our upcoming webinars. And again, thank you to Dr. King and for all of you for being with us. And we hope you have a wonderful, wonderful day.